morning, the head of the department, pharmacy department. Good morning, pharmacist yesterday, income pharmacist, my colleagues, ladies and gentlemen. My name is Ghazali Yusuf Ghazali with matric number 1231 I'll be presenting a case on diabetes mellitus food syndrome. But because diabetes mellitus food syndrome cannot occur without the presence of diabetes, I quickly share a little light on what diabetes is. It's a metabolic disease condition that is characterized by frequent urination as long as the blood sugar level is persistently increased than the normal range. It can basically be type 1 or type 2, but type 1 is managed by the usage of insulin, but type 2 is managed by some other classes of hypoglycemic drug. King All reported in 1998 that by 2025, about 300 million people globally will be affected with diabetes. And the complications of diabetes, it can result in blindness eventually by the path of retinopathy. It can result in heart attack, heart failure, but the focus of this presentation will be the neuropathic complication which results in diabetes mellitus food syndrome, which can result in amputation. Diabetes mellitus food syndrome is actually an injury to the food that is resulting from persistently high or high level of glucose in the blood for a long period of time if it's not treated or addressed effectively. It's been seen under prevalence that about 3 to 7 people, 3 to 7% of diabetes will eventually come down with diabetes mellitus food syndrome. The pathophysiology is such that the nerve cells don't get enough oxygen and nutrients, and as a result of that, they get injured due to the high level of glucose. Based on this injury, the injury could occur on the foot, and this injury could progress and become infected, deteriorated, as we'll see in my patient. Also, immunopathy can be one of the pathophysiologic pathways to diabetes mellitus food syndrome. The risk factors are listed there, but most significant is the fact that too much pressure on the foot when you have diabetes can result in diabetes mellitus food syndrome. Also, a previous occurrence of the syndrome can be a predisposing factor to a future occurrence. Now, here is a picture of a leg ulcer that has resulted from constricted and tight shoes. Like I pointed out the other time about too much pressure on the foot when you have diabetes. The diagnosis can be done by neuropathic investigation or arterial vascular status investigation. The classification based on Wagner classification goes from 0 to 5 depending on the severity of diabetes mellitus food syndrome. The principles of treatment mostly involve the management of the wound. Now, it becomes a pharmacological issue when we need to administer drugs to manage the infection. But aside that, the syndrome is majorly managed by making sure the wound gets healed on time. Also, there are reconstructive vascular surgeries that can be conducted in some other parts of the world. Also, the treatment, like I said the other time, the treatment is focused at managing infection if there is an infection of the injury. But all other treatment managements are actually to make the wound heal faster. I'll be taking a case review of patient AR. She is a woman, 45 years. She lives in Kaduna but was brought to the University of Ilorin Teaching Hospital for treatment. She was admitted November 25, 2015. She complained of injury to her right leg, severe injury to her right leg that was bringing out discharge, and also some mild injury to the left leg, and at the end of the day, it was found that both legs were injured, and she was admitted on account of bilateral foot ulcer that had already lasted for 2 months. The history of the patient was that she has been a diabetic patient for some time. In fact, at the Kaduna General Hospital she went to, she was administered anti-diabetic drug a long time ago, but she stopped taking the drug because she attained a good glycemic control. Also, she has a positive history of diabetes in her family. She is not an hypertensive patient as seen by a normal blood pressure, 120 by 80 millimeters mercury, but significant is also a very high level of glucose. She presented with on admission about 23.7 for the random blood sugar test. Examination of her left and right leg was done, and it was found that the injury on the right leg was so severe as depicted above, 12 cm by 8 cm, depending on as taken by the doctor for the dimension of the injury. Hematology results showed normal ranges, slightly low level of PCB and red blood cells, but a significantly high level of white blood cells, indicating the presence of an infection. Also, the electrolyte level showed creatinine level going beyond normal ranges. Aside that, all other electrolytes fell within normal ranges. Now, the glucose level chart since the time she's been admitted shows a progression of high glucose level when she was admitted initially, but when she began to take drugs, as we will later see, the blood glucose level began to drop, and it dropped to an extent that it also became a problem, as we will see, that when the blood glucose level are high at some point, based on medications they begin to drop, and also based on those medications again, they drop beyond the expected level, and it becomes an hypoglycemic crisis, or a potential one. So the diagnosis was bilateral diabetes mellitus food syndrome complicated by hyperglycemic state and also hypoglycemic crisis. When she was admitted first, she was placed on soluble insulin to quickly crash the level of blood glucose, but over time she was switched to the mixed insulin when a slightly good level of glycemic control was achieved. Also, vitamin A and vitamin C were admitted on admission. For the infection, ceftriaxone was given, but because of some factors like cost implications, she was switched to some other antibiotics, ciprofloxacin specifically. Also, lisinopril was given on some of the days. That's the chart of all the drugs she was given over therapy, but pioglitazone was given 19/1/2016 to ensure that the blood glucose level is more better controlled. The pharmacotherapy of the drug was that insulin was administered to control the level of sugar. All these hypoglycemic drugs are administered to ensure that she has good glycemic control. Ciprofloxacin was administered for the infection together with metronidazole. Clopidogrel was given to prevent the dislodging of clot because she's been in the hospital for a long period of time into the heart that will result in some other complications. Vitamin A and C were administered to hasten the healing of the wound. Lisinopril was given because of the slightly high level of creatinine that could imply nephropathy or a potential or tendency for nephropathy. That's the update, but most important on the update was the fact that she was offered endoscopy, she was offered skin graft as a measure to make the wound heal quickly, but she declined because she could not afford it and also she was scared of the procedure. The drug therapy problem I figured out was that drug interaction existed between lisinopril and glimepiride. She was admitted, and also ciprofloxacin and glimepiride. So on account of this drug interaction could be the reason why the blood glucose level has been fluctuating based on higher level of potency of glimepiride in this patient. Also, the patient might need an additional therapy based on further investigation. The patient has been diabetic for some time. There is a tendency for retinopathy, a tendency for nephropathy, a tendency for too much of lipid dyslipidemia in this patient, but all these investigations were not conducted. The focus was just on the neuropathic situation. If they had been conducted, there might be indication for newer drugs. The care plan goal is to prevent the occurrence of hypoglycemic crisis as seen by the fluctuation in glucose level, and also to ensure that the complication of diabetes is quickly detected and managed. So if the investigations are conducted, we can easily detect the complications and manage them, and also to ensure that the wound healed fast enough to ensure that the wound healing process was very fast. The plan specifically now is to recommend to the physician that the patient should be monitored for hypoglycemia, and also whenever there is an hypoglycemic emergency, she should always have glucose so as to quickly come out of the situation. Also to advise the physician of the need to examine AR for other complications such as assessing the EGFR yearly to check kidney function, checking her lipid level, checking some other, and if there is any abnormality detected, she can be placed on new drugs. To enlighten the patient on the benefits of other non-pharmacological therapy that include the consumption of garlic, cucumber, eating moderately fruits and vegetables that will enhance the healing of her wound and also help her keep good glycemic control. Also to advise the patient to learn to wear neat stockings after discharge, after the wound has healed. She should wear neat stockings to protect her legs so that she won't come down with something similar. Also to advise the patient to obtain a self-glucose monitoring kit to take her blood glucose on a daily basis and make sure that it's kept within normal range. The prognosis, a good glycemic control was achieved with anti-diabetic medications combined, and the wound was healing, it was granulating well, and it was discharged as such for follow-up visit. Here are the references. Thank you very much for listening.
Thank you very much. We'll take 1 2 comments. Interns, you are not commenting. Comments. Let me see those who want to comment.